Okay, perfect. All right, so we're just gonna get right into it to kind of appreciate everyone's time, especially Jason's. So, thanks, Jason, for joining the party.
Oh,
These,
yeah.
just to reiterate to everyone, the goal is to really just open it up and have people who, want to ask questions to any of our mentors to have it be kind of an intimate environment to ask questions or to just listen in and, get a variety of clinical athlete mentors to provide their input and their opinion. So that's really the goal of these. We'll always cap it at 45 minutes. If some of the mentors have to leave earlier at the 30-minute mark, that's totally cool, but should be in and out. And then, yeah, Jason, you want to give like a real quick intro in case people don't know, and then we'll just open it up.
Sure. So I'm a physical therapist at University of Rochester Medical Center. I'm in the sports residency right now, which finishes up in a few months. I've been practicing for 4 years. Prior to this, I was in private practice in Ithaca, New York. So kind of middle upstate New York. Worked with a lot of endurance athletes. So definitely my population that I'm really interested in are runners, middle distance, track and field, that whole kind of thing. Um, Big interest in footwear and strength training as they relate to endurance athletes, as maybe some of you have heard if you listen to the Clinical Athlete podcast. It was exclusively on footwear for an hour and a half. Um, and yeah, so I guess from a sports PT standpoint, I like treating all sports injuries, but the endurance population is really my go-to.
Awesome. So this really is open up to anyone who has any general questions, running related, residency related, because Jason's in the middle of his. And if no one has any, I have some. So
Yeah, hi, Jason. Thank you for taking the time to do this. Really appreciate it. Tristan Barrera here. I was just wondering if in what ways is gaining a deeper understanding of running and just footwear influence how you train strength and conditioning athletes, mid-distance runners and long-distance runners specifically?
Yeah, it's a good question. So I think the only thing that comes to my mind in the footwear, how footwear and strength training cross is there's kind of two areas. One would be if somebody is really interested in wearing a minimalist shoe, or they want to transition into a minimalist shoe, or they're a competitive runner, so they have to wear a minimalist shoe, which is a track bike at some point or another. And so for that, I think we would kind of default to something in the strength training program should be biased towards the lower leg. So the calf muscle complex, maybe some accessory work with the intrinsic foot if we feel like that's applicable. Um, we know that when somebody transitions into a minimalist shoe or even is wearing a minimalist shoe, there's just more load in the foot and ankle. So it's not good, it's not bad, just is. And so if they're prepared for that type of loading from a tissue capacity standpoint, then some of our strength conditioning accessories are going to be focused more towards that. For me, in strength training with endurance athletes, every session has a calf muscle complex exercise. There's no way around that, basically. Um, the other thing that I think is kind of we don't know yet, but we're kind of throwing some ideas out there, is with some of the new marathon racing super shoes that seem to offload the foot and ankle a little bit. Some folks are kind of proposing this idea that, like, because the foot is getting offloaded a little bit more, if somebody chronically trained in a shoe like that, then they might see weakness there down the road. I think an argument against that is these shoes you can usually train in more. So does training more with a little bit less or a little bit more foot protection end up equaling out to training less, but with less foot protection? We don't really know. But for some of those folks, maybe you throw in an extra accessory related to the foot and ankle, just to kind of give them something that they're maybe missing from their training. But yeah, I think from a footwear standpoint, how it relates to strength training, it would just go back to the basics of tissue capacity. So get them prepared for the type of footwear that they need to be using.
Mayday. Her Wi-Fi might be really bad.
Yeah, I'm not getting anything on
Yeah.
my end.
And if you want to text your question, or not text it, just put it in the chat.
Mhm.
While she does that, I have a question. So I have a patient right now who's on my caseload who's a long distance track athlete and cross country runner collegiately. And she's had plantar heel pain. She saw a podiatrist, told her to take like 3 weeks off of running. And we've slowly reintroduced like a walk run program within the past 3 or 4 weeks. But to me, it's this very like ambiguous, like, where do I start? Of like, if someone has completely stopped running, but she, prior handled higher volumes, where do you like, what's your general principle with reintroduction if it's from zero?
Yeah, so this is a big point of the like, how do you customize a walk run progression for the individual? Because we know that there can't ever be a standardized return to run program. There's too many different backgrounds, people getting back to different things, people different running volumes, different tissue involved. So something that I really like that I kind of got from Eric Greenberg, who I've talked to a lot about running. He's a big running guy out of Stony Brook University. He's a professor there. We kind of like this idea of you have to assess at least 4 or 5 different things. So the type of tissue involved is always kind of has to come to the forefront. From whether you're working with somebody with a stress fracture, where you're going to be much more concerned about the type of tissue involved, because our return to run progressions are going to be much more conservative with bone stress injuries, or the it's tissue sensitivity. We don't really see much damage. Go if you feel okay, which is really more the end of the spectrum plantar heel pain is on. And we call it plantar heel pain because in every case, it's like non-specific low back pain, right? There's probably any number or just one of a tissue involved that we just haven't figured out what's the cause yet. So it could be a plantar fasciopathy. It could be an actual bone spur. It could be fat pad related. Could be any of the 3. And so we kind of have to just be okay with this is plantar heel pain. And we know that from an exercise standpoint, we're not going to make anything worse. It's going to get too sensitive to do any type of significant damage before that actually happens. So from a thinking about the tissue standpoint, you'd probably say like plantar heel pain, I'm going to give them a little bit more slack. You then you have to take symptom severity and irritability into account too. If it's the kind of thing where they run 10 steps and then they're sore for 2 days, it's like, yeah, this is going to have to go slower. There's no way around that. We got to cool it down before we start to build it back up from there. And then you have the conversation of like, what's the minimal actual amount of running that you think is worth doing, rather than just not running for some extended period of time before you start a return to run progression. Because is running 2 steps worth it? Probably not. Is 30 seconds worth it? Maybe. I don't know. So those are probably like the first 2 that are kind of like hard stop. After that, that's gonna change a lot about how you structure the walk run intervals. After that, it's a lot of the, well, what's the time frame that they need to be back by? If there isn't a set time frame, then cool. If there is, then there has to be some accepted risk of doing something more on the liberal end than maybe they would have otherwise. After that, it's, well, what's your training age? How much volume were you handling prior to that? Or how much intensity were you handling prior to that? Depending on what the real trigger for the injury was. If it's something that seems to be more like, yeah, this flares up when I hit a certain number of miles per week, or I hit a certain distance to the run, but it doesn't seem to be too bad if I'm doing interval training, then you kind of have your, like, you're out to do one thing versus the other. Those are kind of the main ones. And then, what do you need to get back to doing, and how soon do we need to do that? Then structuring the frequency of the return to run program, because you could say take a day of rest, you could say take 2 days of rest in between this thing, and give them the basic. Your pain should be back to baseline within 24 hours. The whole pain rule that we use for tendinopathy and patellofemoral pain. I think that makes a lot of sense for plantar heel pain, but I think also appreciating that the natural history of plantar heel pain is so long, and in some of the cases, if it's a true plantar fasciitis, yeah, it could clear up within a week or so, but most of the time we see them, it's not going to be that. And so setting the expectations then, like, this could potentially be a really long process. And if you're okay with still having some pain as you get back into the return to run progressions, as long as this doesn't get out of control and we can get you back to performance, then it's essentially like treating a tendinopathy.
Perfect. Thanks, man. I think there was like a period, I think the beginning of last week, where I just like, when she came in, I asked like, how are you feeling about this whole process? And she was like, I mean, I'm running 2 minutes on, 2 minutes off, and my heel still hurts. Like, and it was interesting because she's very reserved, and I felt I could realize she was frustrated. And so we had a more in-depth conversation of like her like level of pain of any level is like stopping her from continuing. And so we had a conversation of like, how much can you tolerate, and like if there's some that's manageable, that's okay. And more so on the realm of like pushing, you know, the mileage or pushing the volume, as long as there is, as you said, like that 24-hour response or something. So a better understanding of like, it's not going to immediately go away, like the sensations within this month that we're working together, but like, can you continue to progress with like that resolution of symptoms within a, you know, a manageable time frame?
Yeah, I think a lot of the time with plantar heel pain, the disability is associated with the severity of the symptoms. So especially for like the collegiate runner who now can't run after they've probably been doing 70-mile weeks or something like that, it's not that the actual sensation is the problem to them. It's that sensation represents that they can't get back to their sport. And once you break that interaction of like, actually, I can have this sensation, and now my body's tolerating running this much volume when it couldn't tolerate this before, then the sensation doesn't really matter, which is good because it still doesn't go away for like a year and a half. So we need to probably get people more comfortable with that. I could keep talking about plantar heel pain if everyone wants.
You see Anne's question?
Yeah, I just popped up here. No problem for the Wi-Fi. Yeah, so Chris, you want me to read the question for like the recording? I don't know if comments.
Yeah, that'd be great. I don't think it pops up on the recording.
Yeah. So the question is, it seems in my world, social media, North Carolina, runners continue to view manual therapy as key for recovery, especially at the elite pro level. What's your take on this? And how do you have a conversation with someone who looks up to elite pros and sees that as the way that they stay healthy? I know this isn't unique to runners, but I still struggle with pushback from runners despite discussing all of the other things that elites do to stay healthy in addition to massage, chiro, etc. Yeah, this is tough because it is the same conversation in like all sports of the how much of the passive modalities matter, and from the recreational standpoint comparing to the pro standpoint, there are so many different things, right? It's like we value the like shiny tools and the passive modalities because we see that, but do we value how hard it is to be a professional athlete and how none of us actually want to do that? Like how being a professional runner is running 2 to 3 times a day, sleeping, eating, and only that. You pretty much just eat, sleep, run, and repeat multiple times a day. It's like not a great life actually. And for it pretty much goes for like most endurance sports, cross country skiing, cycling. The whole thing is the person that can tolerate the highest volume training usually ends up having the best fitness. And so at that level, they're going to do whatever 1% or 2% of those like passive modality placebos are going to get them there. because they have the resources to invest in it. They have the money and time, and they're at the level where you probably just have to roll the dice on something like that because it's not going to do any harm. And I think it just comes down to getting people to realize, like, from not everything that happens at the elite level is applicable to the recreational level. And it's the same as like the high school athlete that we treat post-op ACL reconstruction in the clinic who's not doing 8 hours of rehab 6 to 7 days a week. They're going to see us once or twice a week if they're lucky, and then having to do a lot of other stuff on their own time. Like, there is just a difference, and some of that is resources, and the other is, well, you're not also doing all of the other stuff that you need to do to stay healthy or to train. So nobody likes the idea that the basics are pretty much just boring, and you can do the bulk of a sport by not doing anything that exciting. You know, that's the same reoccurring debate about passive modalities.
What about, oh, go ahead, Tristan.
Hey, Jason. So speaking of the calf muscle complex, in relation to like that positive shin angle that we get during sprinting, how is the gastroc able to withstand being lengthened at two joints? Is it just not an area of concern or something? And then how do you mimic that in sessions if it is an area of concern?
So, are we concerned about the gastroc from a sprinting standpoint? Is the first
Yeah,
question.
just on its ability to still be able to produce force at that lengthen.
Yeah, I would say that we probably should always be concerned about it, since it's probably the second most common sprinting injury, the calf strain, second to the hamstring strain. Yeah, I mean, the calf is responsible for 50% of force production and probably a little bit less than that for your easy running, and it stays pretty close to 50% as you get up into sprinting. So to me, there's no way to mimic that other than to sprint. It's kind of the same thing as like the how do you prevent hamstring strains? Well, you should probably have sprinting in your repertoire if you're trying to prevent a hamstring strain. You should probably also do that if you want to try to prevent the gastroc strain. Can you mimic it otherwise? Well, you can do really heavy loaded gastroc exercises. I in particular like the Smith machine for gastroc loading, because you take balance out of the requirements. You can get the knee straight, you get the forefoot up on a plate, and you can load it up as much as you want. But at the end of the day, you can do as much lifting, as slow, heavy lifting as possible, but it still has to do its job as it does in sprinting. And so even if you're doing something like that, if you're doing single leg pogo hops, that's probably just one way to condition it, but getting some regular exposure to high speed running probably has to happen.
Do you, for patients that come in that are runners, is there, and let's say they have not resistance trained before, is there always a discussion like going forward about the potential importance? Are there ever periods where you're like, I never bring it up, I don't even need to mention it? Yeah, how do you go about that?
Yeah, I always ask it on the first day whether they have a resistance training background, and then I kind of gauge their initial willingness to start if they don't. See what their resources are, if they belong to a gym, if they've had resistance training experience in the past, but have just not really been doing it for the last few years, or maybe even it's just like when they started a new training cycle, they haven't been resistance training because they were focused more on building up weekly frequency or volume or something like that. I do think it's an important thing that runners should do. I probably don't push it as much as I did a couple of years ago, and I think some of that is just the evidence that we have for it is on performance training right now. So I'm less and less confident that strength training reduces running injury risk. I think it theoretically can, from a tissue capacity theoretical standpoint. But to me, the more important thing for a lot of runners is knowing how to structure an adequate training plan, or just having a training plan, basically, because the number of runners that you see in the clinic that just aren't following any specific schedule, other than just like, sometimes I go out and run and I don't know how far or how fast, and sometimes I don't. Those are the ones that are probably gonna accidentally get into a situation where they do too much too soon, which is kind of what we think causes all running injuries. So yeah, I think if somebody's like, if it's a performance situation and somebody they're training hard and they've never resistance trained before and they want to improve their performance, I think it's pretty low hanging fruit. If it's for the recreational runner who we're treating their running injury, I'm much more concerned with just actually rehabbing their injury, finishing off the injury, and making sure that they keep that injury, or that site of the injury, relatively strong, while then keeping a pretty sustainable training plan. And if they're interested in strength training after that from a performance standpoint, I would offer a program like that. But yeah, that's kind of where I'm at, just based on the current state of the strength training literature. I'd be very open to change that stance if we see some things roll out that shows that it can significantly affect running injury risk. Little plug there, actually, for my AMSC talk, which is going to be a debate on whether runners should strength train. Hope I didn't spill all of it.
Yeah, going back to that case study, the patient I have with the plantar heel pain, I'm conflicted of like, okay, well, she's not going to stay in rehab forever. And then the college that she's at, the long distance runners aren't trained by the SNC coaches, but the sprinters are. And so it's like, is there a need to have a conversation about, how much weight do I put in emphasizing like a long-term approach to like once or twice a week of maintaining this? And I haven't brought it up because I'm like, is this something she needs to do? Is it more stressful than anything of like her trying to make the time for it, trying to like actually have a positive adaptation? And then will it actually like reduce the risk of future injuries? And so you kind of answered that last part, but it's just like a recurring thought in my head every time I see her of like, she's going to be gone in a month or two back to school. Where do we end this?
That's a good point. If it's a collegiate runner, I'm going there. Because their thing is performance. And so if they have an inadequate strength training routine, and for us, inadequate is probably defined by most running standards as like the typical very high repetition, low weight circuit type training, which they're essentially just getting already by running. So if they're not doing some sort of like calf conditioning or quad multi-joint exercise type stuff, then to me, that is then low hanging fruit to just sell as like, this is going to help your performance. Do this 2 times a week. Doesn't even take that many exercises or that much time. You can micro block them wherever you want throughout the week, as long as they don't interfere with your running workouts. That I think is solid to sell. When it comes to plantar heel pain, this is a direct quote from Greg Lehman: exercise sucks. So it doesn't seem to do a whole lot from a rehab standpoint, and it doesn't also seem to do a whole lot from a prevention standpoint. It's like I was a huge fan of the windlass heel raise for a while, and there's a new, I guess, like PhD dissertation. So the paper isn't out yet, but Henrik Reel, who's been on a couple podcasts talking about plantar heel pain, I think he was on the E3 podcast a while back. One of his studies was looking at like self-dosed versus the heavy slow resistance thing for the windlass heel raise. The windlass heel raise, for those not familiar, is like where you have your toes propped up on a towel and you're doing the heel raise and then prop it down. So you basically create a windlass mechanism every time you're all the way up onto your toes. And the self-dose versus the actually like HSR protocol doesn't really make that much of a difference. Nobody really does that great. And then this new trial that he has that hasn't come out yet is basically comparing corticosteroid injection, the heavy slow resistance exercise, and like advice, and all of them basically do the same. And the same is like 30 to 40% of people are not super happy by the end of it, and the end is like at least a year out. So that was kind of like a man. I loved the idea of treating this like a tendinopathy, but I don't think it's really panning out that way. Now that said, like nothing wrong with getting somebody's calves stronger under any circumstance, and that I'll take to the grave. Yeah.
Are there any subjective complaints that you'll hear from a patient or a runner or an athlete that'll lead you to say, you know what, I got to take a second look at how those calves are functioning, how those calves function with fatigue, and just how those calves function under load?
Yes. So the main thing in my mind that comes up is if somebody is complaining of like persistent fatigue that then turns into vascular symptoms, which is a pretty alarming thing for like a compartment syndrome. So somebody's like, yeah, I get this calf cramp, and then I start to get some tingling into my feet, or like some numbness or cold feeling into my feet, and then it doesn't go away until a little bit after I stop. That's early signs of compartment syndrome. So that's definitely one of those like can't miss that type of sign type things. There is kind of like the spectrum of calf muscle injuries too, where it's like it feels really tight when I'm warming up, and then by 5 minutes in, it kind of goes away in the absence of a mechanism of injury too. And those are kind of like the probably low end. You still put them under the umbrella of calf strains, but it's kind of just one of those like, yeah, the muscle's not doing so hot right now type injuries. There are some other things just physiologically, like soleus aponeurosis tears and things like that we can't diagnose from a physical standpoint. They appear to just be your run-of-the-mill calf strain. And those are probably the ones where it's like, yeah, if we've given this a solid loading program for a month or so and we haven't made much progress, then there's probably something else going on here, and definitely not a bad idea to get another pair of eyes or some imaging on this thing.
I think Anne has another question in the chat.
Oh,
She said, resistance training doesn't necessarily reduce risk of bone stress injury. That was a question. I realize if someone adds strength training when there's some red S going on, that doesn't reduce risk. And I guess that is tied to the majority of BSI, but I thought it was supposed to be helpful loops.
So I guess the problem with when we compartmentalize general versus specific running related injuries is the statement X doesn't reduce the risk of running related injuries. X is whatever we're talking about. Running related injuries is every single running related injury. So that would include bone stress injuries, tendinopathies, pretty much everything. Strength training might reduce the risk of certain types of running related injuries. So from a specific running related injury standpoint, that's where, yeah, maybe like improving bone density via strength training has like very good plausibility to decrease the risk of bone stress injuries. And there was a cross-sectional study, Nussbaum in 2019, that basically looked at high school runners that had bone stress injuries, those who didn't, and the ones who did not have bone stress injuries were weight training like twice as much as those who did have bone stress injuries, which is a finding that kind of in our minds is like, oh yeah, the ones who are lifting more didn't have as many bone stress injuries. Maybe resistance training helps with that. The way that study was obviously conducted was retrospective, so you can't take a cause and effect out of that. To date, there's not a prospective study that shows that strength training reduces global or all running related injuries. And then it just comes down to, well, we probably need to start investigating specific running related injuries. And that's not a new concept. That's not like somebody having a brain blast and saying like, wait, why don't we subgroup all of these things now so we can actually take a look at differences? Because the problem there is that with running related injuries as a variable, and then you cut them up into 50 to 100 different injuries or more or less, depending on how you subgroup different things, that means you need hundreds of thousands of runners to actually get the numbers that you would need to then subgroup each of those different types of injuries that comes up, so that when you analyze them, it didn't just produce a bunch of false positives and random noise. And then the problem then is like, will we ever have enough data on rare things like sacral bone stress injuries to say like, yes, this is why they happen and this is what fixes them and all this stuff? We barely have enough data on the most common running related injury, which is patellofemoral pain, because that represents maybe 10% of all running related injuries. So if 40% of people in a study get injured, which is kind of on the high end, but is seen in some of these cohort studies, you have say you take 1,000 runners, and that's more than are in most trials. 40% of them come out as injured, so you have 400 injuries, and then 10% of that is patellofemoral pain. You have 40 cases of patellofemoral pain. Now you can maybe cut that subgroup one or two different ways before you're cutting it too thin and increasing that risk of a false positive. So I can probably think of more than 2 or 3 things that I'd like to analyze to see if they're related to patellofemoral pain. But if we're so limited from that, from a statistical analysis standpoint, then something else, like the current model of how we're researching this is not going to get us that much further in that respect. That was a bit further off topic from bone stress injuries and running related, and strength training. But it kind of goes to the point of like, we can't figure this stuff out most of the time. Theoretically, it makes sense to have people strength train. And like you said, if somebody's already in a state of relative energy deficiency, not a great idea to add more of an energy deficit to them. That's obviously an example that where strength training is not the answer. But yeah, from a prevention standpoint in normal population, theoretically makes sense. I would still do it, but I wouldn't be too confident about it.
Okay, I have 2 questions. One, if you have a runner, let's say, I don't know if your answer will change. Let's say they're not elite. They're just they've ran for multiple years. It's their hobby. They do it a lot. They primarily run on flat surfaces or even like on incline or decline, but it's not on a trail. And then you have a runner that's just a trail runner. Are there ever conversations with those 2 subgroups of like introducing some type of like trail running to a non-trail runner and then introducing some type of flat ground to a trail runner? And if so, why?
I would ask them, where do you race? If somebody exclusively races on road, then I would say probably don't bother running on trails unless you really like to run on trails or you'd like to run on grass or whatever. But from a performance standpoint, you're going to get the most then of training on the surface that you're going to race on. If they just run on trails, probably run on trails. Gets the body prepared for the task. That's from like the movement variability standpoint, I think we can get the most out of doing different types of runs at different paces. I think that's where you'd get more of that, like the traditional idea of like in the gym, the training different movement patterns to get better at like one specific movement pattern. In running, it's the training for performance at the road 5K. Well, do most of your runs on road, do a bunch of them easy pace, sometimes do tempo, sometimes do race pace work, sometimes go a little faster than that. And the variability just comes with that. There are also folks who advocate for wearing different types of shoes because it slightly changes the loading profile of the foot. I wear different kinds of shoes because I've got a problem. I don't really think that it changes the look that my foot is getting too much, but yeah, I think it's train how you're going to race, or train where you're going to race is the short answer to it.
And then second question, from a, I know that an easily manipulated variable is stride rate for potentially someone who has some type of running related injury, and you can like manage that pretty well. Is there any other thing, because that's obviously changing biomechanics to a certain extent, but it's almost like a secondary effect. Is there anything that you're ever like coaching or cueing specifically to change the actual like presentation of a runner, or is that just such a hard thing to do that it's not even worth it, and it's not even like potentially, you know, valuable?
Yeah, that's great, because that just, it opens up like the whole conversation about changing somebody's movement patterns, and does something that we do in the clinic actually on a treadmill actually transfer to overground in the first place. I think the reason cadence has become so popular, and rightfully so, is because it does seem to be the one thing that we can actually change and see lasting results, even if it's like 2 weeks later, 4 weeks later. The longest study I think was 12 weeks in cadence follow-up. We have devices that can give us feedback on them in real time, and that's how I prescribe it clinically. Is if somebody has a Garmin, they can set a cadence alert on their Garmin to just beep at them if they fall below a certain threshold or they pass above a certain threshold. And to me, that's like the only thing that I actually see working from a giving people feedback standpoint, instead of the like, put a song on that's whatever beats per minute that we think is 5% faster than the thing that you're self-selected to right now, or even just the every minute or every 2 minutes in your run, I want you to think about slightly increasing your cadence. I don't trust that any of that stuff works. I do trust that people get annoyed by a beep on their watch and then slightly start to increase their stride rate until the number says the number that they need to be at, and then they will do that for some extended period of time before falling out of it again. But that's the one. Oh yeah, yeah.
The stride rate, are you changing it by 5%? You mentioned that. Is that always like the initial go-to, or how do you depend on that percentage?
Yeah, I'll usually just demo out 5% and then have people see how it feels. It really is like the range is 5 to 10%, but 10% for somebody who's never worked on that stuff it feels pretty uncomfortable, just from like a I don't know what I'm doing standpoint. And it does end up then it worsening the running economy, or increasing the cost of running if you get like to that 10% and higher range, which is why the original Heiderscheit paper was like, all right, the reason we're looking at 5 to 10% is because it seems like if you're changing just this amount, it doesn't negatively affect running economy too much. If you change more than 10%, then it does. That was basically just like an average that they saw in some of their initial research. So
is that something that you would change long term, or would you ever resort back to the initial cadence stride rate?
Oh man, I don't know. This is something I just go back and forth on so much. To me, I look at it like, if this is a first time offense, first time you've had this running related injury, I would say don't worry about it. Especially if the onset was very clearly like, oh yeah, I started doing help repeats. My body wasn't prepared for it. Like some very obvious too much too soon etiology for their problem. I would probably have them just go back to doing what they were doing. But if somebody is coming to me with like a 10-year history of patellofemoral pain and or multiple bouts of patellofemoral pain, or any other anterior knee pain pathology, where we're just like, you know what, if your goal is running, I think I'm okay with just shifting a little bit of load away from the knee here. I think then it's like, here's the information. This running this way does this. You can choose to use this for the rest of your running career. You can go back to how you were doing it before. you could go back to how you're doing it before. And then if you need to, you can use it again, or you can just run like this now. That's usually how I'll use it in like more of the chronic cases. When it's really, really hard too, is if it's somebody's first injury, which it's rare that I see somebody's first injury, but in the high school population that I work with, sometimes I am seeing somebody's first injury. So when that's the case, it's like, geez, they didn't have any other injury prior to this. I'm probably just going to use this as a temporary intervention and then send it back on their way. And before anybody asks, because the follow-up question is, do you use it in the population that's never gotten injured to just like see if there's an optimal cadence or whatever? It's pretty rare that you ever see a runner who's never been injured. And even if you did, I would just not change anything. I just don't think it's worth changing anything in a creature that's already so fragile. Like we're just like, it's a Kaplan-Meier curve, and the survival is just decreasing continuously. And it's at some point that runner is going to get an injury, and I don't want to be the reason why somebody was associated with it, whether or not it even was the change in cadence that did it. It's just one of those, if it's not broke, don't fix it situations. Yeah, that's my stance on cadence. There's folks that will advocate for improving somebody's overall running form by increasing stride rate or reducing reducing loading rates and reducing overall peak vertical ground reaction force by increasing step rate. And it doesn't come without risk. There's nothing that we do that just eliminates risk completely. It just shifts things around a little bit. So we always have to remember that too. And that's why changing somebody's foot strike pattern has fallen out of favor in a lot of clinical practice too, because it's just a riskier version of taking load somewhere and shifting it somewhere else.
Awesome. Does anyone have one final quick question? If not, we can wrap it up.
Hey, Jason, real quick, this is Quinn.
Hey.
Am I wasting my time doing seated calf raises when I could just do standing calf raises?
Oh, this has been killing me lately too. Greg he's been going off on this, and yeah. I don't know. I see his point, but at the same time, I think that I'll say this, the easy answer first is if somebody has had a soleus injury in the past, then I think it makes a lot of sense to isolate the soleus by doing knee bent calf raises seated, so that it puts the gastroc on slack in active insufficiency, and then it forces the soleus to do more work. I don't know now about the, do we do seated calf raises sometimes? Do we do standing other times? I think I still approach it like the same way that I approach a lot of other strength training, which for me is because I'm not trying to get better at specific lifts. It's, if I'm going to do some type of squat variation on one day, I'll change the squat variation for the other day, or I'll do rear foot elevated one day, front foot elevated another day, because it's just working on slightly different versions of the same thing. So I'm not ready to give up on seated calf raises, I think is my synopsis on it. I'd be interested to hear your thoughts.
Oh yeah, they echo yours. I'm with you. I don't know, so I'll just keep doing them until. Yeah. Cool. Thanks, man.
Yeah.
Yeah. Thanks, Jason. This was awesome. So these will be recorded, uploaded to the thread. And then I think the goal is to do these once a week, once every other week, and just have rotations of mentors. And I think this was a great setup. What'd you think, Jason?
Yeah, this is cool. It's kind of just like hanging out, talking about stuff, fielding questions. Thanks for having me.
Yeah, I appreciate it, man. Sweet. Well, thanks for everyone for joining the party. Enjoy the rest of your Thursday night. And then we'll announce the next mentor talk at some point later this week. It'll probably be for next week, but it'll be an email or thread. So yeah, everyone enjoy the rest of your night. Thanks.
Cool. Thanks, everyone.